So thank you for inviting me down here to speak. It's a great program today, and it's really great to see the COSA guidelines as part of the program and have the opportunity to talk to you all about how we have developed the guidelines and some of the challenges that we've actually faced and controversies with the guidelines. So I'm going to talk a bit about how we got to where we are with the guidelines, and I'm going to touch on the content. There is obviously a lot of content, but I'll show you some of the landing pages and then talk about some of the implications of the guidelines. So my profession, as you know, is a cancer pharmacist. I've been a pharmacist and worked in cancer for most of my career, for about 35 years, and was very aware of safety and quality from when I first started. My first sort of introduction to a complex chemo protocol was in London, looking at one of the MRC leukemia protocols, which, if any of you have seen, are huge, and I was amazed by the content, but realised how easily and quickly things can go wrong if you just simply slip up with a zero or follow the wrong arrow. So safety and quality with cancer therapy has always been a keen passion of mine, and it's been really good over the years to see things develop and some more sort of stricter guidelines and recommendations coming out around how we can make chemo safe for our patients. And I shouldn't say chemo anymore. I know it's cancer therapy, and I'll talk about how we've defined cancer therapy, but chemotherapy really now is encompassing everything, the immunotherapies, targeted therapies, monoclonals, and the traditional cytotoxic chemotherapy. So the long name for the COSA guidelines is the Safe Prescribing, Dispensing and Administration of Cancer Therapy, which is a bit of a mouthful, a bit like a haematology protocol. So we often abbreviate it to Safe Delivery of Systemic Cancer Therapy. The guidelines were developed by a multidisciplinary group of oncologists, nurses and pharmacists with support from librarians who are from the Austin here in Victoria and a COSA project officer. And they actually provide a revision of the original guidelines published in 2010, which were published in the AJ Australia Pacific Journal of Clinical Oncology. And I'll show you a few more of the pages, but this is just what the landing page looks like. Now, I don't think the screenshots of the pages will look great on this screen, but I didn't want to risk doing an internet connection live because I've seen those go horribly wrong. So the aim of the guidelines is really to provide a framework of recommendations to minimise medication errors or potential harm when we give cancer therapy to our patients. And so we want to give our cancer therapy in a way that maximises the safety, and that includes not just the clinical process of making treatment decisions, but the whole process through from communicating prescriber decisions, what the pharmacist does, and how the nurse gives the cancer chemotherapy. And we know from experience in all healthcare areas that error reduction is maximised when we take a multidisciplinary approach with all professionals being involved, and we make the patient that centre of our care, and that we don't just look at the clinical process, we look at our procedures that we're using within that process. So, as I mentioned, the scope includes all the processes, so it includes prescribing, dispensing, administration, and for the pharmacists here, when we say dispensing, we mean clinical verification, the actual labelling and the supply of cancer therapy. And we've defined cancer therapy within the guidelines, as I mentioned, as all antineoplastic agents used to treat cancer through all routes. Now there are, as well as oral and IV, there's a myriad of routes used, but we've tried to cover off on most of those in the guidelines. So how did we get to the guidelines? We first of all formed a working party, and that was done by putting out EOIs to the COSA community, and we had a good response, put together some expert professionals and expert subject matters for the guidelines. We then sent out a survey to everyone to find out how useful they found the guidelines, particularly anything they thought was redundant or could be added to the guidelines. And that was important. It did highlight to us that a lot of people actually weren't really aware of the guidelines, particularly medical staff, because we had responses saying, I'd actually never heard of them until now. But we also had some very useful suggestions about the guidelines. We then followed the Cancer Council's process for putting guidelines onto the Wiki platform, and that's a fairly a big document, but provides some really good guidelines about doing reviews, forming recommendations, and actually putting those up onto the Wiki platform. So if you haven't come across this document, it is very useful if you're looking at developing guidelines. So why did we choose to use the Wiki? If we think about what makes a guideline good and something that everyone wants to use, we want it to be reliable, we want it to be of high quality, we want it to be current and applicable, and we want it to be easy to use. And using the Wiki platform within the Cancer Council ticks off on all these requirements. Particularly, it makes it available to everyone, so you don't have to subscribe to a particular journal or be able to access a particular journal. They're also easy to navigate, or most people that get used to how they're navigated think so. So you can easily get to the place where you want to get on the guidelines. And the reference sources are all linked within the guidelines, so you can actually see the original abstract or web page that's used to support a recommendation. So the current structure of the guidelines is there are 37 answerable clinical questions, and these have all been developed using the traditional PICO formula, so patient population, intervention, comparator, and outcome. And the guidelines have been organised to cover off on the general processes applicable to everyone providing cancer therapy, and then the roles of each professional group within provision of cancer therapy, so the prescriber, the nurse, and the pharmacist. So I won't list all 37 questions, but if you Google Cancer Medication Safety Wiki or Cancer Council Wiki Medication Safety, you should come up with the guidelines in your search within the first few searches. But examples of the questions that we've posed within our guidelines that we've answered are: what are the documentation requirements to support the safe provision of cancer therapy? What information should be on a treatment protocol, and I think that's very relevant now in light of recent events. Additional practices needed when providing oral chemotherapy, the use of complementary therapies with cancer therapy. And many of these were questions and recommendations that we covered off previously in the guidelines. So a lot of the actual recommendations aren't new, but we've actually provided more information to support some of the questions and recommendations. And particularly within each of the individual groups, we've got role-specific questions. So how should the prescriber document and communicate the treatment plan? How should the pharmacist be verifying cancer therapy? What information and assessments are required by the nurse prior to administering cancer therapy? So those are all the questions that we posed in order to actually then answer and provide recommendations and practice points. So again, that's the landing page. Again, if you come up with this page, that's what you'll see first. And you'll see on the left-hand side, you'll get a background to the guidelines, a bit about the process we followed to get to where we are with the guidelines, and then the tabs here for the individual professions and their role. And each subsection is then split into the questions. So here I've brought up the page on the treatment protocol, and within each question there is an introduction to that section, a recommendation and references, and also tables where required to refer to for each section. And the recommendations in the NHMRC recommendations, they're split into the A, B, C, D, and then consensus-based and then practice points. And I'll talk a bit about why most of our recommendations were consensus-based shortly. And again, not putting this up for you to read in great detail, but then if you drill down into each recommendation, you'll see that you can get a summary of the recommendations and then also a list of the practice points. So in terms of actually navigating the guidelines, if you've got a specific area you want to find some information on, you can easily get to it from the left-hand tab and find out what's in that section, rather than, as you might do with a printed guideline, having to look through each page or do a search on a PDF. So what's new? We have made some changes to the new guidelines. We've added in some more detail on calculating doses for adults and for paediatrics. We've also provided much more information around what we would call high-risk medications in cancer. Cancer therapy is by nature high risk, but there are certain medications in cancer that are even more high risk than being high risk, if that makes sense. So we've included highlighted areas such as trastuzumab emtansine, which can now be confused with trastuzumab Herceptin. We've highlighted where there's different formulations for rituximab and trastuzumab, where you have IV and subcutaneous formulations, and they can easily be confused because they've got different doses and different routes. We've also added new sections on complementary therapies. We've expanded sections on paediatrics and geriatric or older adults. And we've included an expanded section on electronic prescribing programs. That in itself has been challenging because there's a lot of information out there, but it's very hard to make clear-cut recommendations. So although that provides some basic recommendations, it wasn't possible to really go into a huge amount of detail. So what were the challenges we faced when developing the guidelines? Using the PICO formula did pose some challenges. We're looking at an area where there's often no clear-cut randomized control studies. We're looking at the processes applicable to safety and processes that may cause potential harm. Attempting some sort of trial for those processes is obviously not appropriate and is not actually going to, is not appropriate because it may cause harm to the patient. So most of our recommendations, there was no high-level randomized control evidence for that recommendation, and it was based on things like published incidents, case reports, other government reports that were available to us to make recommendations. We utilised the expert opinion of the group to actually make some of the recommendations as well. So those were consensus-based recommendations. And I've just put there the how you formulate the NHMRC guidelines criteria. So ideally, when you're making a guideline and you're making a recommendation, you want A or B, but in our case, we had to go with consensus-based recommendations. But through the years, as we apply processes to safety in cancer therapy, we get to understand and know that those processes mean that we have a much better way, much safer way of delivering therapy to our patients. And just, again, I won't go through all of this. Our initial search strategy brought up 1,744 papers, of which the majority were not applicable to you or useful to our guidelines. We used about 185 in the end, which included some of those papers, plus government papers and grey literature, which the group were aware of. So the evidence base for our recommendations included a lot of the case reports and papers on the inadvertent administration of vincristine via the intrathecal route. Now, our understanding of how risky it was to put vincristine in a 2 ml syringe became apparent when a number of cases worldwide occurred when vincristine was accidentally injected instead of methotrexate into the spine. So we learned from other people's mistakes, and we now have very strict criteria which we need to follow when providing vinca alkaloids and intrathecal methotrexate. Some of the recent incidents in New South Wales that have been talked about this morning and in South Australia we use to inform our guidelines, and some case reports that we know involve patient harm where full packs of oral chemotherapy or chemotherapy hasn't been appropriately labelled and patients have misdosed because of that. And there is also very old literature, but still supports our recommendations, such as how we put the information into a protocol about whether information should be given, or whether the drug should be given on day 1 and 8, and that's often been mistaken as day 1 to 8. And there's a very old case of where vincristine was administered daily for several days because of the misinterpretation. And then we have examples of recommendations for each discipline-specific role. I don't think that's a very busy slide, so that's just to show some of the examples of the recommendations. Altogether, we had 177 recommendations, so that's a large number of recommendations, but those are within both the general information and within the individual discipline-specific recommendation. A particular area that I'm very passionate about, and it was very good to hear Bob Thomas talk about this morning, is quality assurance activities in cancer therapy. So we always need to look back and look at how we could have done something better and also learn from other people. We've recommended in the guidelines that there should be a process in place for reviewing adverse events and near misses. And near misses is something that we often don't report enough and we often don't publicise enough. We all pick up on what we would call near misses on a daily basis, particularly pharmacists and nurses. They may take them back to the person before them, get them corrected. We often don't think of those as something that should be reported. Sometimes they will end up in Riskman or whatever system you use, and often they'll just get, oh yeah, that was unfortunate, but someone recognised that happened and corrected it before it got to the patient. But there's always a learning process there. So it's important that we actually have each hospital has a process for looking at not only near misses, but also adverse events and series of adverse events that may be actually caused by something that people weren't fully aware of. So if you're suddenly getting a lot of chemotherapy-related adverse events, because of a new protocol, then it's important to look at that protocol and see, is there something happening in that protocol? Is it different to the original trial? Do we need to change how we deliver that protocol because the trial setting isn't applicable in our patients? There's often a way of going back and looking at what change is needed because of an adverse event. And similarly, if you're getting lots of unplanned readmissions, we learned that with capecitabine, that in the trials, the incidence of diarrhea was a lot less than what we actually saw in our real-life population, because the trial population was very small, and we needed to not amend the protocol but be much more vigilant with our care for those patients. Another challenge when developing the guidelines is, will they be used or read? So there's no point putting together 177 recommendations if no one's actually going to use them or even read them. We had a plan for dissemination. They were released at COSA. Myself and the members of the working group who are here today, some of the other members of the working group, which is great to see, have spent a lot of time promoting them, but it's not just a one-off promotion, it's a constant dissemination to make sure people are aware of the contents of the guidelines and where to find them. The other important point is, will they be used, or can they be used in practice? So we needed to consider with our recommendations if there were any barriers to implementation. Are we suggesting things that just simply are not achievable in the Australian population? Are there resource implications? Are we suggesting something that has huge resource implications? And that's sometimes for many sites a problem with electronic prescribing programs, where they are a huge cost, and some people simply have not had the investment into those programs. And also where they sit alongside accreditation and national standards, we needed to think about how they could sit beside them. So we did open the guidelines for public consultation for a month, and we did get a fair number of responses to that. So there were a few controversies, comments, support of the guidelines, but that's very important with guidelines, that we do open them out to the professional community, but also they were available to the public community as well, because the Cancer Council website is available to anyone. So some of the controversies that were raised were, we didn't have a patient on our working group, and that was not a purposeful decision. It was considered that these were professional guidelines, but I did agree that perhaps for review, an ongoing review, that we should have a patient representation on the working group, particularly to look at some of our sections on information and patient engagement when we discuss their treatment with them, for those safety barriers. The lack of haematologist on the group, by nature COSA is oncology, and we didn't get a haematologist on the group, but I did manage to encourage one of our haematologists at the PA hospital to provide some expert opinion during the consultation phase, which was very useful. Some people felt these weren't really applicable to their site because they were in a rural area or because they were a community pharmacy, and that's something that needs to be addressed. They are applicable to everyone, but regardless of where you work, safety is everyone's business. Interestingly, some people were concerned that they weren't printable, so they wanted to be able to print the guidelines. We haven't made the guidelines available in a printed version. However, the website now, different pages can be PDF'd. So if someone wants to access a particular section or the entire guidelines, you can PDF them and print them. However, there is that proviso that they are only current for 24 hours. Because one of the advantages of the wiki is that if we want to change the guidelines, update them, we can do so anytime, and we don't have to republish the whole guidelines. We can update a particular section and just put out a reminder that it's been updated. Other controversies were the practicality of recommending everything was prescribed on a separate chemo chart, particularly targeted therapy. We have included targeted therapy as cancer therapy, so I still feel that's the most appropriate way to prescribe targeted therapy, and that's probably something that needs to be addressed in the future. There were also concerns about restraints on sites that had small numbers of staff, where we've recommended a 2-person check and there may be a sole pharmacist working. Again, there are provisions around that, and I don't feel that it would be appropriate to recommend anything other than a 2-person check for nursing and pharmacy. They are, of course, all guidelines have their limitations, so taking in mind some of the controversies, we do need to consider the population as a whole, and I'm aware that different areas may need to adapt the guidelines according to their need, but with safety paramount and patient care, adapting them not too much so that we may increase errors in our patients. And really it's up to individual institutes to consult with local governance committees to decide whether a certain change in practice does need resourcing, or whether a certain change in practice is not necessary because they feel that they're already addressing that in another safety initiative. But it is really a whole of hospital responsibility. So in summary, the guidelines are an expert, multidisciplinary-based group of recommendations, but the aim of everyone should be to provide safe care to our patients regardless of where you're working or what your profession is. And I think this was addressed well this morning, again, by Bob Thomas, that staff need to be aware of how their own process and behaviours impact on others and the patient. And we do still have some cultural barriers to break down in our hospitals. I know in pharmacy when we find that there's something that's incorrect or not very clear, most prescribers are more than happy to discuss that with us and change that and meet us where we need to be met. But in some cases there is still those cultural barriers where someone else feels that what they've done is best and not prepared to make those changes. But I think we all need to work together as a group to make sure that there's no cultural barriers to maximising safety. Developing guidelines is difficult, it's challenging, it's controversial. We're trying to standardise practice in a situation that's already very complex. So we should expect discussion and controversy when we develop them. Very importantly, the development of guidelines is generally voluntary and it is very time-consuming, as those involved would agree, in assessing the literature, writing the recommendations, and dealing with many of the comments. So lastly, I'd really like to acknowledge the work of the group that assisted in the development of the guidelines and thank them all very much for their input. So thank you.
Thank you very much, Chrissy. It's a fantastic presentation. We're sort of drifting over time, but I think you've come down from Queensland, so there's a little bit of extra concession, I think, for this. The first question I've got here, which came through the system here, I must say I'm not sure I really love this system because I like to see the faces of the people who've asked the question. So the person who asked the question, no, I won't do that. But this question was very much, I was thinking as you were talking, and the question is, are these guidelines instead of EviQ? Can you just explain what your guidelines are directed towards as opposed to being protocols for management of particular cancers?
So our guidelines are statements really about processes that should be followed when you're prescribing, checking, dispensing, administering chemotherapy. So Evacute is clinical based. It has the set of treatment protocols. The guidelines almost define how you should be writing that treatment protocol, almost like a set of behaviours or processes that should be followed. Does that make sense?
It does make sense, yes. So we've got multiple guidelines for various phases of the process. Any questions? Yes?
I think I just like that question, but I would think that I think you should contact the HSAZ, which is equivalent to COSA.
Hematology?
Hematology.
Yeah.
Representation. I'm sure we will be able to provide hematology.
Okay, that's good. We did initially contact them and didn't have a response, but I do have lots of friendly.
Very busy people.
Yeah, I have lots of friendly haematologists in the PA hospital, but we will make sure we contact them again. Thank you.
So the
Oh, okay. Good to know.
You're from South Australia? No. The South Australian issue was about haematology and was about the issue of prescriptions and accuracy of prescriptions. And I'm surprised you sort of slid over the issue of who and how you write a prescription, which is a very complex protocol, if you're not going to do it electronically. You said, oh, it's difficult to go electronic, and I thought you said that.
I'll go all out and say, no, it's not difficult to go electronic. It's difficult to get the money to go electronic. The recommendation is all chemotherapy, cancer therapies should be generated by a computer. Should be a computer-generated prescription, should not be handwritten. If the recommendation is if there is a need to handwrite anything, then it should be very clear. But computer-generated scripts, that would almost make it a mandatory requirement, and I'm not sure how everyone would go. Is there anyone here that still uses handwritten scripts? Okay, so there's a number of people in the room that still use handwritten scripts, which is dangerous, I agree, and is fraught with safety issues.
It's all right for Panadol, but it's not good enough for some of these other things. I've got a question here, which is a significant question. Were nurses consulted in guideline development? I think I saw a nurse. Did you have nursing?
Yes.
On your group?
We had I can't remember, 5 or 6 nurses, but from Victoria, New South Wales. So yes, nurses were part of the working group, and they were all invited during the consultation phase.
Okay, my last comment is that you raised the question of the commission, and the slight benefit of having the Commission of Hospital Quality and Safety, whatever it's called, do similar work is that they can put it into their accreditation system. So they can then demand that the hospitals comply to this, or they won't get accredited. So there's a little bit of extra pressure from that point of view. Look, I think we better move on. Chrissy, thank you so much. It was a really good presentation. Thank you.